So while people filter in, my name is Moyo. I'm the head of the Division of Epi and Biostats, who's hosting today's noon meeting. And I'm very pleased to introduce Dr. Sizulu Moyo, who's a research director in the Human and Social Capabilities Program at the Human Sciences Research Council. She holds an MBCHB, an MPH in epidemiology, a postgraduate certificate in clinical research administration, and a PhD in pediatrics and child health in the field of tuberculosis. She has extensive experience in public health research, and her work is mainly focused in the area of TB, where she has successfully participated in numerous TB research projects, leading multidisciplinary teams and working with local, national, and international stakeholders and collaborators. Today, Dr. Moyo will speak to us about the quality of TB and HIV care among private general practitioners in 2 South African cities. So thank you very much for joining us, Dr. Moyo, and the floor is yours.
Thank you for the welcome, and thank you for the invitation to present this work. I hope you can hear me loud and clear.
Yes, sound is good. Thank you.
Okay. So as has been mentioned, the work that I'm going to present to you is work that we did in 2018-2019 that assessed the quality of TB and HIV care in the private sector. We did it jointly with let me just go back. We did it jointly with McGill and also Dr. Pai. Most of you may know him. And I'm Rita Daftry, who was at McGill at the time, but she's now at York University. Okay, so just to start off with, I'm sure that all of you are aware of the TB Cascade of Care. So I'm presenting there 2 figures. The first one, published in 2016, that really speaks to us about how people navigate care from those who have TB in the general population, if you want to call it that, right up until you get to a much smaller proportion of those who go through all the various steps of being seen at a facility, accessing a test and being diagnosed, being put on treatment, continuing on that treatment, and eventually being cured or completing treatment and being free of TB at 12 months. The bar graph presents the same kind of information, and this is based on data from South Africa, from the 2030 cohorts. I'm sure most of you are familiar with this publication, which was led by Pren Naidu. And I think it tells us really the same picture, that out of all the people who had TB in South Africa in that cohort, which was about 532,000, only 53% successfully navigated the cascade and had treatment success. I know that there is another cascade that has just been done now that is based on data like National TB Survey, and I think that data even puts the last bar at about 46%. So it's clear that not all the people who require TB care make it successfully to the end of the cascade. So we also know that in South Africa, a lot of people, up to 38% of people are estimated to seek care from the private sector. We also know that people do move between the public and the private sector. So the private sector is a significant player when we think about some of the conditions that we have in South Africa, including tuberculosis. In addition, there was a global analysis that looked at patient care pathways. It included South Africa. And in that study published in 2017, it was found that up to 29% of people with TB symptoms first present to the formal private sector before they go to the public sector. This is important because I'm sure, as we all know, most of TB care in South Africa and in many countries in this part of the world is provided in the public sector. So there was at the time when we did the study, and I think even now, very limited data that described how TB is managed in the private sector, especially in a context where there is potential for high levels of co-infection. We know that in South Africa, we've got a high prevalence of HIV. So in terms of what we set out to do, we wanted to measure the quality of care for TB and TB-HIV in the private sector in 2 urban settings, Durban and Cape Town, as mentioned before. We also wanted to look at the no-do gap in the provision of that care in the private sector. So what did the practitioners know and what did they actually do in practice? And another objective was to validate this methodology as an approach to assess TB and HIV care in the private sector. This is the methodology that uses standardized patients. So we identified private sector GPs in these 2 communities in Durban and in Cape Town through online listings and mapping. We did drive-throughs and walk-throughs in the areas where we knew from the data from TB statistics where there was high burdens of TB in those communities. We excluded GPs who were offering specialized care, for example, pediatrics, and those who were doing obstetrics and gynecologies and other specialties. The GPs that we identified and contacted, we consented them to receive up to 3 unannounced standardized patients over a 6-month period. And standardized patients, I'm sure, being at a medical school, you're all familiar with them. They are actors who are trained to systematically represent a complaint or a set of symptoms in a real clinical settings. All our standardized patients were healthy people, and we trained them very, very rigorously in terms of presenting the cases that I'll describe to you shortly, and also to avoid invasive procedures. Some of you may know that this is some of the concerns in this type of methodology. The visits that were conducted in this study were primarily walk-ins, and the standardized patients paid normal cash rates for all the consultations. So now to describe the cases that we had 3 cases. The first case we summarized as somebody who is suspected, a case of suspected TB in an HIV positive individual who is not on antiretroviral treatment. So the script that we trained the SPs to present with was something like, I have a cough, I'm feeling hot and I'm not getting better. And if the practitioner then takes history and probes, they would then report the common symptoms of TB that we know that my cough is for longer than 2 weeks, it is productive, losing weight, have no appetite, sweating at night, and they would disclose their HIV status as being HIV positive. The second case was one that we summarized as a bacteriologically confirmed case. And this is the script where the SP would say something like, I have a cough that's not getting better. I went to a clinic back home, which means out of Durban or out of Cape Town, and I was given some tablets. They took my sputum, and on probing, they would also relay the common TB symptoms as above, and they would actually produce a gene expert laboratory report, which is positive, rifampicin sensitive, and then they would also disclose that they are HIV negative. The third case we summarized as somebody who could possibly have drug-resistant TB, being HIV positive and also not on ART, and they would present with a script which says, I'm suffering from a bad cough. Last year I had some medication, I got better, but now the cough is back. If they are probed, then they describe the symptoms as we know them for TB, and they disclose that actually they were diagnosed with TB in the previous year, and they did not complete treatment, and that they're HIV positive. In terms of the endpoint, we defined it as ideal case management, and we wanted 2 scenarios. The first one being the practitioner offering or sending the SP for any TB or HIV-related test, could be in the private sector, or referring this individual to the public to a public sector clinic or hospital, because we know that in South Africa, in general, people present with these types of symptoms do receive TB and HIV testing in the public sector. And this was all really based on the TB guidelines as they were from 2014. So once the standardized patients went through the consultations, when they finished each consultation, or what we called an interaction, then they went through a standardized survey. Now, this was to extract the information as to what happened during that interaction with the practitioner. And this included asking the types of history questions that the practitioner asked, what type of examinations the practitioner had undertaken, the tests that they had ordered, any referrals that they had made. Some of them were made verbally, the medications that they were prescribed and or dispensed, if there were referral forms or other artifacts such as sputum cups or sick notes or prescription notes for medications. In addition, we had 50 GPs that we randomly selected for facilitated knowledge survey, which included a vignette. And the vignette in this case was identical to case 1. If you remember, that's the person who presents with the typical TB symptoms. They're HIV positive, and there's nothing else, just a typical TB case, which is likely to be drug sensitive. So in these facilitated knowledge surveys, then we probed for management practice details, such as the tests that they would do, the referrals and initial diagnosis. We used open and closed-ended questions about HIV and TB decision-making, common practices concerning when and who they test or when they refer, and also we asked about treatment knowledge and practice. The study was approved by research ethics committees in South Africa and in Canada, and we assured the GPs of confidentiality and only presenting aggregate level findings as we are doing now, and also in the publication that we made. The study, as I've mentioned, was in 2018 to 2019. So moving on to the results, first of all, to talk about the GPs who participated. So you'll see that in this table, there are 4 columns. The first one is around the characteristics that we're describing. Then we've got the summarized data, which is the combined data for 2 cities, which is overall. Then you see the breakdown by city in terms of Durban and Cape Town. So in terms of who participated, most of the GPs were men, 3/4 of them. And in both cities, most of them were men. In terms of where the practices were located, in the combined data, it shows us that more than half were operating in the suburban areas. But if you look at it between the 2 cities, you see that in Durban, most of them were in the CBD and also in what are called township areas, whereas in Cape Town, most of the practices were in the suburbs. Median years in practice as a GP was very long. It was 24 years overall, and also the same in both cities. Most of the GPs saw about 25 patients per day. It was higher in Durban. Most of the GPs saw 25. In Cape Town, it was about 20. Consultation fee, the median was 320 Rand. In Cape Town, the consultation fee was slightly higher. It was 350 Rand. We ended up with 511 interactions that were the consultations that were completed. 43% were in Durban, so more were in Cape Town. When we looked at the consultation time, it was about 10 minutes, and it didn't vary by the SP case, as I've described them to you, case 1, case 2, or case 3. We found that on average, female GPs spent more time with their patients than male GPs. And in terms of detection, because we wanted also to find out whether the GPs would be able to pick out that this was a mystery patient at any given time. There were 9 who were detected, giving us a detection rate of 2.3%. And within this type of work, this is an acceptable detection rate. So in summary, 57%, in 57% of interactions, there were referrals to the public sector. And in 79%, these referrals were specified for TB, 6.4% referrals to the private sector. And in the private sector, most of the referrals were for smear, microscopy, chest X-ray, or a combination of both. Now, when we look at the management outcomes by case presentation, so in this slide, we're showing you the 3 cases and the outcome. The red section of the bars represents what we would term as the ideal management, where there was a referral for a test or referral to the public sector. So if you look at the first case, in 45% of the interactions, that's where the SPs were referred for a test or referred to the public sector. For SP2, which is the case that presented with a lab report that showed that they were gene expert positive, it was 85%. And in the third case, which is somebody who had been diagnosed with TB previously and stopped treatment, it was in 69% of the interactions. So we looked at what factors were contributing to what we call ideal management. And so in this table, I present to you the factors, and we've got it as combined, which I call it overall. And then we've got it by case, the first SP, SP1, SP2, and SP3. So if we look at overall first, we can see that practicing in Cape Town, being a female provider, spending consultation time at least 10 minutes or more, mentioning HIV in the interaction, and dispensing fewer medications, and asking about the common symptoms of TB that contributed to what we call ideal management. When we look at it by case type, the same picture is the same picture for case 1, but for case 2 and case 3, the factors that contributed to ideal management were mentioning HIV in the interaction, dispensing fewer medications, and also just taking a history and asking more about all the other TB, the common TB symptoms. Now, when we look at HIV, in terms of ideal management, for the first case, it was in 41% of the interactions. In the second case, it was in 80% of the interactions. And in the third case, it was in 61% of the interactions. And what are the factors that contributed to ideal HIV management? Again, we can see from the odds ratios that it was in Cape Town compared to the practicing in Durban. Female providers spending a consultation time 10 minutes or longer, asking about TB, and also dispensing fewer medications. When we break it down by case, this is the same picture for case 1. For case 2, it's female providers asking about TB and also dispensing fewer medications. For case 3, you can see that it's all the factors that are mentioned. So practicing in Cape Town, being a female, longer consultation time, taking a history and asking about TB, and also dispensing fewer medications. So we also, we've been talking about dispensation or prescription of medications. So in the interactions that we had overall, in 88% of interactions, there was at least one medication that was prescribed or dispensed. In general, SPs walked away with at least 3 medications. Most of the medications were prescribed and dispensed on site, and the majority of them were in the essential medicines list. We also found that in 32% of the consultations, the practitioners actually offered the SPs an injectable, and there were some unlabeled medications that we could not make out in 6% of the interactions. So the number of medications by case, so this is just to give you an indication. So in the table, we show you the median number of medications and the range. So for the first case, which is what one may call a typical case of drug-sensitive TB potentially, the median was 3.7. And you can see the median there for case 2 and case 3. You can see the range there from 0 to 8. The median was higher in Durban, so they tended to prescribe more medications than practitioners in Cape Town. And we're just showing you just one for one of our SP3s. This is what they walked away with from a practitioner. I think it was a total of 8 different types of medications that they'd been prescribed. So what type of medications were actually prescribed? So it's a whole range of medications, ranging from analgesics, which were the most common. So paracetamol, a lot of it was prescribed. There we see theophylline, we see amoxicillin, we see that there were steroids that were prescribed, fluoroquinolones, anti-allergy medication, also cough syrups were prescribed. So you can just see the whole range of medications that were prescribed, but predominantly paracetamol and theophylline and amoxicillin were very common. We also see that there was ciprofloxacin there prescribed as well. So in terms of the knowledge surveys, remember that we said that we randomly selected about 50 GPs for this no-do gap assessment. We ended up doing this in 49 of the GPs. So in 39 of the 49, in SP1, they had ideal management for TB, but in practice, only 21 of those 49 had ideal management for TB. So there was that gap between from the vignette and what we found what they actually did when the SP had presented to their rooms. 27 of the 49, which is 55%, had ideal management for HIV, but in practice it was 37% who had ideal management for HIV. So some providers indicated that the management that they undertook differed by the payment method. Cash paying patients would mostly be referred for tests in the public sector, and those who were on medical aid would be referred for testing in the private sector. And the private test offered preferences differed. So most of the practitioners identified smear microscopy and chest X-ray as the first port of call test for them, for patients presenting with these symptoms. And it was, we understood from these interviews that they preferred smear microscopy as the first test because it was cheaper than a GeneXpect in the private sector. So we wanted to also know when GPs suspect TB or HIV versus what they did. So this is from the knowledge surveys that I mentioned before, and compared that to what they actually did in practice. So in the knowledge survey, 63% said they suspect TB when there are at least 2 common TB symptoms. In practice, it was actually higher. In the knowledge survey, 83%. In practice, it was 89%. And then you can see for the other symptoms, weight loss, night sweats, and fever. The other factors that they say they consider are if people are living with HIV, they think about TB. When there is a non-contact or when people present with symptoms like hemoptysis. For HIV, about 1/5 of the practitioners said they would consider HIV in all patients that they see. There are some who say they consider HIV when people are wasted, when people have skin problems, these were not defined, when people were looking ill, when they reported things like chronic diarrhea, having STIs or frequent illnesses, then they said they are index of suspicion for HIV was then higher. So to move on to the discussion, we concluded that GPs have a good understanding of TB symptoms and referral practices, but there are differences between what they know and what they actually practice. The optical management of TB symptoms is nuanced. So when it comes to testing, more than half of the SPs received broad spectrum antibiotics and other medication, representing lost opportunities to reduce transmission and disease severity. So they receive these medications without having opportunity to be tested first to determine whether they have TB or not. And I know that this is one of the things that is addressed in the TB guidelines. In the private sector also, they mainly preferred to send people for smear microscopy rather than gene expect, which we know has higher sensitivity. And here the nuances are issues around cost and whether people can actually afford to pay for gene expect. In terms of time spent with patients, we found that longer consultation times were most likely to result in SPs being referred for testing or referred to the public sector, things that we defined as ideal management. We also found that there is a lot of provider tenacity, that GPs actually go the extra mile. They do consider their patients. Sometimes they reduce or waive the fees to facilitate that people do get diagnosis and care. For example, we know the issues of the public sector in terms of high patient loads and waiting. Sometimes if patients could not really go, the GPs would do their best to see how they get them to navigate the system. Sometimes GPs would call ahead in the public facilities where they refer to just make sure that the patients do proceed to go there for testing or further follow-up. GPs performed better when TB was part of the case description. That's when we had higher proportions of ideal case management. Performance was better overall for TB than for HIV. We found that HIV was queried in less than 25% of SP1 interactions. So if they did not volunteer, the GPs did not ask them, despite the patient presenting with typical TB symptoms. TB for performance in this case was better than for private sector GPs in other high-burden countries. We have compared the findings in this study with findings from Kenya and also from India, where a lot of this work, especially India, has been done. In South Africa, we know that there was a study that was done in the Eastern Cape and Cape Town, and gene expect tests were conducted routinely in 81% of the cases, and sputum and HIV testing in 43% of the patients that were seen. We found that ideal management was associated with improved inquiry into symptoms, so taking time to ask about the common symptoms, a longer consultation time, and mention of HIV or TB, and that female GPs did better than their male counterparts, and that GPs in Cape Town did better than those in Durban. Most GPs identified smear microscopy with or without chest X-ray as the initial test in the private sector, and we know that some of this is driven by cost factors. So obviously there were strengths and limitations. We know that the SP methodology reduces observer bias when compared to other methodologies of looking at quality of care. This is one of the few studies that has looked at TB care in the private sector in South Africa, and it builds well on existing well-documented methodology. But there were some limitations. So we did not record the interactions. Obviously, it would have been an ethical issue that we had to consider. So there might have been limited recall or recall bias from some of the SPs, but we trained them very rigorously, and we conducted all the interviews after consultation as soon as possible. So there was always someone who was waiting for that SP on completion of their interaction, so that survey could be done to extract and collect the data. We also know that real-life interactions may include novel practices, accents, or jargon, which some of the SPs may not have been able to recall. We had informed consent of providers. So in other countries, we know that this types of studies have been done without consenting the providers, but we, given the nature in which we would conduct research in South Africa, obviously they could not participate if there was no informed consent. So there might have been some bias, with GPs with greater clinical abilities or interest in this type of work may have been more likely to consent. So we may have overestimated if those who were not with less abilities may have been excluded from the study by not consenting. So to conclude, we found that general practitioners in South Africa, specifically Durban and Cape Town, performed well, as well or better in terms of TB management compared to private practitioners in other countries. But when we compare it to the study that was done in the public sector in the Eastern Cape and Cape Town, the levels were lower. Prioritizing testing, spending adequate time with patients, and going beyond the routine scope of practice resulted in better SP management. Reducing losses in TB and HIV management at first encounter will require innovative partnerships between public and private sectors. I think this is very clear given the level of referral or testing that we saw in this study. Our findings reveal that there is a gap between knowledge and practice. And also we found that optical management is more nuanced than knowledge or symptom recognition. We saw that GPs considered issues of cost, for example, when they decided what type of test they could prescribe or request for their patient. And we did show that this methodology is feasible and is acceptable in the private sector in South Africa. So in terms of implications, so what we found is that the current practice that we found in this study suggests missed opportunities for early TB diagnosis in the private sector. There is also missed opportunity for HIV detection and initiation of treatment. So we think that there is a need for more public-private partnerships. There is a need for structured referral pathways between the private and the public sector. There is a need for targeted TB and HIV refresher courses for sectors for GPs in the private sector. We know that in the public sector, there's a lot of these that take place, but in the private sector, maybe they may not be as frequent as, they may need to be. We are aware that SAMA and other such groupings conduct a lot of GCP-related training and refresher courses. And we also found that our findings differed by city. For example, practitioners in Cape Town did better than practitioners in Durban. So it will be interesting and important to focus on areas of gaps or weaknesses that affect GPs in each particular city. So in terms of future research, systematically reducing delays in appropriate TB and HIV testing and treatment will require innovative strategies to promote your interaction between the private sector and the public sector. And we also need to empower GPs to consistently inquire about HIV. So I want to acknowledge all the people participated in the study, and also to let you know that this work was published in the BMJ Global Health Journal, and I'm sure if you search for it, you can find it. Before I finish, I just want to talk about another study which really came up from this work. We presented the findings and the gaps and what some of the implications are. So writing on from that work, we are busy with a Connect TB study, which is reducing TB diagnostic and treatment delays in the South African private sector. And this is a study that is linking patients in the private sector to testing for TB in the public sector, so through the NHLS system. And these are the people involved in that study. We are led in the study by Dr. Tulufelo Mhlaba, who is based at UKZN, and Dr. Jody Boffa, who I think some of you may know, but is based in Durban at the moment, and hopefully it may also present some lessons that can be useful for other settings. So as I've mentioned in summary, we are linking patients who present with TB symptoms who require testing straight to NHLS, and it uses it's through a VULA system, the VULA system that some of you are very much aware of, and I know it was used very widely also for COVID, especially at the beginning. I'm sure it's still being used now. So when the practitioners consult a patient who may have TB symptoms and they feel that the patient needs to be tested for TB, they no longer have to think about what is the cost. Should I send them for smear microscopy because they can't pay, or the private fees? There is a pathway that we have created for them to capture that information onto the VULA system, and that alerts the study team, who then goes and collect the sputum sample, and that is then taken for testing at the NHLS system in Durban. So the study started in about May, and these are some of the results that we have so far. Obviously, with the riots or the community unrest in the last few weeks, there was some impact on the study. So just in summary, if you look at this, so we've got the study week, and then we've got the number. The gray line represent the GPs that we have engaged. So it's almost a similar way of engaging the GPs as we did in the SP study. Fortunately, we had some of them already in the database, and so it was easy to email them again about the study and seek their consent to participate. In the blue line, you can see the specimens that have been submitted. And I think for me, what has been striking is the expert positivity. So you can see the expert positivity that we're seeing in this study so far. It just shows us that there are a lot of people who are walking around with bacteriologically positive TB in the community, who are seeking care from the private practitioners before they even come to the public sector. And so if there's a way of narrowing that gap and bridging the ability for them to be tested rapidly and put on treatment, it's very useful. So this just summarizes what happens in that study. I think I've mentioned it to you in terms of the symptoms and the data being entered into VULA, and then the specimens being collected and sent for testing to the NHLS system. Thank you very much. That is the end of my presentation.
Thank you very much, Dr. Moyo, for the very comprehensive presentation. So we have about 20 minutes for questions and discussion. And so if anyone in the audience wants to raise their hand or put a note in the chat, please do so now. We have a quiet audience. Okay, well, I'll start then with a question that came to mind. So I'm not very familiar with this this area of research actually, but are these kinds of findings similar to what you see in the public sector as well, in terms of sort of missed opportunities for diagnosis and treatment rates, or are there big differences between public and private sector?
When we compared our findings with work that was done in the Eastern Cape and Cape Town clinics, and I think this was mainly with the nurses, they performed better than what we found with the GPs. And our thinking is that in the public sector, TB and HIV are very top of mind. We know from the TB and the HIV guidelines, especially the HIV guidelines, that you do have to assess people for TB whenever you do HIV testing. Also the same for TB, you always have to test people for HIV whenever you suspect or test them for TB. So in the public sector, it seems the message is more upfront because this is where most of these infections are managed, and the testing is the guidelines are clear, and the guidelines are much more easily, I think, adopted and practiced with the burden of disease and the fact that most people with these conditions go there in any case. So the public sector did much better than the private sector based on our study.
Virginia, oh, something's wrong with my thing. Virginia had a question in the chat. Do you know if any of the GPs were any of the patient's usual doctors, or were these all one set of doctor visits? And do you think this would have impacted the performance of the GPs? So you're very quiet again.
Okay.
You're very quiet.
Now? Can you hear me?
Yep, it's still a little bit soft, but go ahead.
This closer. Okay, I was saying that's a very important and interesting question. So these were once-off visits because we trained these people to present as these mystery patients. So they were not their regular doctors. One would assume that maybe if a patient is very well known by a doctor, maybe the history taking, the questioning, and the management might be different, but it was just a once-off visit, and yeah, it's possible that it may have changed if they were repeat visits or if they were known to the practitioner.
Thank you. Any other questions? I see a hand. Julian, go ahead.
Hi, thanks very much. It was a very interesting study. I guess I was a bit alarmed to see that smear microscopy is chosen as a diagnostic because it's cheaper when the standard of care is gene expert, and I suppose that does speak a lot to the sort of knowledge gap and the divide between a public sector where TB and HIV is, as you said, top of mind, and a private sector where it is less so. But yes, I suppose my comment was that we really do need some better intersectoral collaboration, and where the private sector are able to manage TB and HIV and receive updates more frequently. But thank you very much. It was a really interesting study.
Thanks. Dr. Moyo, do you want to respond to that, or can we take another question?
I'll respond quickly. I think this study underscored that. I think most people kind of know that, but this study is so objective, shows us objectively that this is the case. And one of the things that we did throughout the study was to engage SAMA as well, because we know that many GPs in private practice are members of SAMA. So in some of these webinars or sessions that SAMA does, it's imperative that, some of the gaps are closed through those interactions, and we did engage with them. And through this other study that I mentioned, we continue to engage with them, and we hope that some of it will begin to bridge that gap and make sure that the standard of care is the same between the public and the private sector. But thanks, it's a point well noted.
Thanks. Vanessa, please go ahead. We can't hear you if you're talking. Still nothing.
Now?
Yes, now is fine. Thank you.
Oh, sorry. I think, thank you for the study, very interesting results. And I think one of the problems that private sector is not using gene experts, so it costs them about R1,000 plus for gene expert versus 200 to 300 for the cultures. And the other problem is also that TB is not really a PMB currently, so they will only refund it if it's a positive TB case, and only certain schemes would also do it. So I think that's quite a big problem at the moment for not supporting TB protocols as we would have liked. Thank you.
Thanks. Dr. Moyo, if you have a comment, please go ahead. If anyone else has questions or comments, please raise your hand or add into the chat. So I think that is everything then. I don't see any more hands going up or questions in the chat. So once again, Dr. Moyo, I just want to really thank you for coming to give this talk. It's very interesting, and hopefully we can hear more about your study as the next one carries on. So thank you again, and thanks everyone for attending, and enjoy the rest of your Thursday.
Thank you. Bye.
Bye.
Thank you.
Thank you.